So when we talk about when they really have no choice, have to remove the breast, if those who like doesn't have any medical illnesses, actually they can opt for breast reconstruction immediately or delay type.
Okay.
So even though they lost a lot of skin, but we still can find out other place, Sometimes we do combine with our plastic surgeon together to rebuild the new breast for them.
UM Specialist Centre isn't your typical hospital. It's Malaysia's premier quaternary hospital where rare, complex and next-level care comes to life. This is Quaternary Care, where our team of trusted super consultants are here to take on your toughest health battles using advanced technology and research-backed treatments all under one roof. Now, back to Nadia Azmi for UMSC's QRATED podcast.
Hi everyone and welcome to QRATED, brought to you by UM Specialist Centre or UMSC. I'm Nadia Azmi, your host for this podcast, and today's topic is about something that affects thousands of Malaysians each year, predominantly women but also men. It is about breast cancer. Maybe you are going through breast cancer, or you have a mother, auntie, or you know someone, a friend, a relative who is going through breast cancer. So this topic or this episode should be very important to you. Now, from diagnosis to surgery and everything in between, it is life-changing when you hear the doctor say to you, you have breast cancer. So what happens after that? What is the treatment journey like? How does it affect a person's body, physically and also emotionally? What will they go through? What will you go through if you are experiencing this? So joining me are two incredible experts from, of course, UMSC. We have Associate Professor Dr. Adlinda Alip, a Consultant Clinical Oncologist. Welcome, Prof. Adlinda, to QRATED.
Thank you.
It's great to have you. Yes, in pink. As well as Professor Dr. Mee Hoong, a Consultant Oncoplastic Breast Surgeon, here to walk us through the medical side, also the emotional side and everything in between. So welcome to the both of you doctors, Prof. Adlinda and Prof. C, both of you in pink, love it, as well as me as well. I mean, in honor of what we are talking about, which is breast cancer. So I think the color pink, there's a lot of significance to it. And we have our pins here. It says hope. I really like that. I think because when we talk about the medical side of breast cancer or any cancer, we always think of it as very dark, very solemn, very hopeless. But I think it's very important that they have a support system. Your patients have a support system, including the doctors, to make them, to ensure, to make them know that, there is a way out of this, or there is a way to make yourself taken care of. So enough of me talking. Now we want to know, apart from being women, to the both of you, why did you choose this field of going into breast cancer care? Why do you choose to be specialists in this area? Maybe I can start with Prof. C.
Yeah. Okay. I think breast cancer, like what just now, what you say is it involves two, right? Female and male, right? Mm-hmm. So 99% of breast cancer patient is female. Right, it really like close to our heart, So the reason of I'm joining this field because I love surgery, first one.
Okay.
And I'm choosing a field that very close to us, So female breast cancer. So that's the reason I joined in the breast surgery field, and that's me. Yeah.
How long have you been a specialist in this area?
Around probably since 2015.
Okay.
Yeah, about 10 years.
All right.
Yeah.
What about you, Prof. Adlinda?
Yeah, interesting because you mentioned about it's quite a depressing kind of.
Yes.
I did a general medical training prior to actually get into oncology.
Mm-hmm.
Before I started my training in oncology, I did a fellow job. And actually, at that time, it's an eye-opener. And I fell in love with the specialty because it's not as grim and depressing as I even myself thought before I trained in this field. Because we also have cancer survivors and even patients with stage 4, we treat to improve their quality of life and prolong their life. So it is satisfying and rewarding. At the same time, breast cancer is common. It gets a lot of attention. There's a lot of research, etc. There's a lot of development. So it's kind of exciting field as well. So
I think that's what keeps your passion and the fire alive in what you do in your professions, right? You're not just the bearer of bad news, but it's beyond that. I think when you engage, when you talk to all these cancer survivors, it gets very inspirational.
Yeah.
I think. What about you, Prof C? What keeps that drive there? To be a surgeon. It's not easy. You learn surgery, but it's not a small task. It's a mammoth task.
I think as a doctors, we always we are the problem solver, you know. So when I move on as a general surgeon to breast surgery, then we see there's a lot of still a lot of things that we need to improve. Especially we call oncoplastic or aesthetic part, that when we do surgery for our breast cancer patient, after the surgery they need to live on with whatever they have, you know. So that drives us because a lot of them have all this low self-esteem, very scared to go out and join the society community, you know, because they feel like they don't really very confident for themselves, you know. So that drive me to go and look at the new things, new surgery like oncoplastic surgery. And now we move on to minimally invasive to hide the scar for them, you know, surgery and breast reconstruction to rebuild their new breast for them, you know.
Yeah.
All this is very, very exciting, and patient come back with smile into your clinic.
That's
you know.
very rewarding,
Yeah,
I'm
very
assuming.
rewarding, yeah.
Let's go back to the basics. I see that we have a prop here in the studio. Can you tell us what is breast cancer? And like Prof. Adlinda mentioned earlier, it is something common. So it is getting more and more common in Malaysia from one year to another. Can you tell us first, what is breast cancer?
Okay, right.
Yeah.
So we can see here. So breast cancer, actually there's two types of tissue that involve in our breast. You can see the parenchyma, or what we call breast tissue that producing milk, you know. You can see the breast duct here, and when the breast duct go further, they will have a end of here, which we call terminal ductal lobule unit.
Okay.
That unit is the one that producing milk, you know. So when the cell in the duct of this breast duct, we call it, as well as the lobule change, then it become a breast cancer. But we also have other parts of supporting the breast, you know. You see fat tissue here, fibrous tissue. All this also can change, become cancer, but we call them another type. So like we call they are stroma type, which is not
But
common.
it's still breast cancer of a different type.
And some lymphatic channel here also can have cancer, you know, lymphoma. Sometimes we do have a lymphoma in breast. So all this, but they are not common. The common type is we call invasive ductal or invasive lobular.
I see.
That cancer happen in the breast duct. So all this, right, they will start with a duct inside the duct, but slowly when they invade to the tissue surrounding, then they become invasive. The early type we call ductal carcinoma in situ. In situ means still inside the surrounding environment and haven't come out, like you haven't go out from your house, you know, you're still inside the gate yet. So we call ductal carcinoma in situ, which is stage 0. When they invade and go out from the house or from the basal membrane, we call it, then they become invasive cancer.
Okay, and so you have just explained where it comes from, where the cells are that becomes into cancer. But we know that one of the symptoms is, you know, you get lumps around your breast area. Maybe Prof. Adlinda can add on. What happens after that when the cells become cancerous and the symptoms start to appear?
Okay, so basically breast cancer is uncontrolled growth of breast cell. Okay, it's not because of injury or stress. It is at cellular level. They change somehow. There are mutation that change the DNA and that produce the cancer, which starts with a lump So you can feel breast lump. It's can usually tend to be hard, not necessarily painful. So that's one of the symptoms. Sometimes patient might notice like the breast is different from the other side. Either it shrinks or it kind of swollen, or the change in the skin, persistent change in the skin, or they can get symptoms from the nipple. Either is become abnormal, it's kind of withdrawn, or they can get discharge, which can be bloody. So these are kind of some of the symptoms.
The early symptoms that someone, an individual will be able to see.
Yeah. Or, if they go for screening, mammogram, then that mammogram can detect the breast cancer early.
Okay.
So that's also important.
And this doesn't happen just to women. Predominantly, yes, to mostly the patients that you see are women, but this happens to men as well.
Yeah. I actually, it can happen to men. It's rare, but I have one male patient currently.
Okay. But in the whole of Malaysia, how would the statistics look like between men and women cancer based on gender?
Majority
Breast cancer.
are women. Like Prof C said just now, more than 99% women. But there's a small, very small.
Men is 1%.
Okay,
Yeah.
1%.
Yeah.
This is for Malaysia, but I think globally it's about the same.
Yeah. It's the same.
Okay. Besides those symptoms, any other typical symptoms that a patient should be aware of, should be on the lookout for?
To us, right, the important is to detect the cancer early, you know. So when we say we want to detect early, so it only will present during our screening time. No lump, no pain, no discharge. But there's the changes, like Prof. Adlinda said, overgrowth of cell in the dark only can present in mammogram.
Okay.
Other than we talk about other symptoms, like maybe it's already spread, stage 4 disease, they can spread to our brain, liver, you know, sometimes lungs. Then the symptoms that they present is totally different already. It's like organ-based type of a problem.
Yeah. Is it true that mammograms are very painful?
Of course, because we need to, mammogram normally is like you have two platform, like when we put our breast on the lower platform, then above the top one will slightly press down, and then they rebound back. So that press, because we need that, because if not, then the X-ray cannot penetrate our tissue. So that part causes a little bit of pain.
Okay.
Yeah.
And I think maybe it's a myth as well. We've heard some people say, oh, don't go for screening, don't go for mammograms. That can actually cause cancer. Is that true? Prof C? Prof Adlinda? No such thing, right?
Yeah.
But I've heard, people saying or throwing that theory around. And for mammograms, I think it's advisable that those who are 40 and above, that they really should go for a screening. Is that right, Prof Adlinda?
Yeah. I think it's finding the right sort of age, because like you said, there's always pro and cons, because mammogram involve X-ray.
Yeah.
So, but it has its benefits, so you have to balance it.
Yeah.
So I think the decision is 40, above 40.
Okay.
Um,
And then how regularly should one go for a checkup after that?
Currently it's every 2 years, just to like balance, the X-ray exposure.
And I think there are certain factors that an individual should also take into consideration, including whether, they have it in their family, breast cancer. It could be inherited. So then that would be a bigger push for them to go in for a screening even earlier than 40, maybe. I think a lot of people have taken that precaution.
But the issue is our mammogram cannot detect breast, the abnormal cell in the breast too early, because in the early age, right, our breast is very dense. Dense means whatever we can see in the mammogram is all white color.
Oh.
So above 40, yes.
I see.
Yeah, easier to detect anything that hiding inside the breast.
Okay.
But before that, we are not encouraging our people or our female to do mammogram before or younger than 40 years old.
I see. But I mean, you still get patients before the age of 40, before they reach the age of 40 who get breast cancer.
Yeah.
How do they usually detect breast cancer? Is it usually because of the lumps that they feel? Yeah.
Mostly it's lumps or symptoms like what you say just now, like some fluid came out from the nipple, like bloody type of blood stain. But a lot of time when we see how can we detect early, we did run a study in our Malaysian women.
Okay.
Young breast cancer we do have and can see more and more. But then mammogram really cannot really help to detect anybody that less than 35 years old with a breast lump. Actually, we do use other adjunct type of investigation like MRI, or ultrasound that adjunct to the MRI for those who less than 35 years old below.
So they go for MRIs instead.
If we find
detect
they
breast
have
cancer.
something abnormal,
Right.
then ultrasound not very sure because ultrasound is not a good tool for screening, So we will sort MRI.
Okay.
Yeah. So that's like young age. Normally they are more genetic inherited group as compared to the common like 40 and above. Generally they are sporadic type, means it's not due to the 40 genes. Yeah.
Okay. Now take us through the journey of a breast cancer patient, Prof. Adlinda. How does it happen from diagnosis until treatment? Take us through the process.
Okay. Usually, patient would see the breast surgeon for diagnosis. So they would have some sample from the lump taken
Okay.
through biopsy, and then with that, we will check what type of breast cancer, like Prof. C mentioned earlier, and we check how active, so the grade, and we also need to check the different receptors, so the hormone receptor, the growth receptor, the HER2 receptor, and how active the Ki67, the marker, how active the cancer is. We also look at the size, so we have to do imaging, the mammogram, ultrasound, and also we look at whether it's spread elsewhere to stage the patient. So normally we do either CT, thorax, abdo-pelvis, and bone scan, or we do a PET scan, which is a kind of combination of both. So once we have all that information, of course we have to see the patient in front of us, how old is the patient, how fit, what other medical problem the patient have. Based on all these factors, then we would formulate the treatment for the patient. The main treatment is actually surgery. For early stage, it's surgery. But surgery alone, there is, for some patients, there's risk of the cancer coming back. So we need to give additional treatment to lower the risk as much as possible. So the additional treatment include chemotherapy, radiotherapy, targeted therapy, the HER2 targeted therapy, or the kind of cell cycle targeted therapy, and also hormone therapy. So for each patient, we would consider their risk and whether how much this other treatment contribute to lower the risk of the breast cancer coming back, hence to achieve cure.
Okay. What are the differences between chemotherapy, radiotherapy, and also targeted therapy?
So chemotherapy are drugs that target fast-growing cell.
Okay.
So tumor or cancer, usually they are fast-growing. So they are the main target. But in our bodies, we also have other kind of fast-growing or turnover cells, like our hair. It grows all the time. Our nail, and the lining of our gut from our mouth to our, small, large bowel. So they can be affected by the chemotherapy.
I see. Okay.
But the idea is the chemo is even fast growing sort of cell, so it would be targeted more. Okay. So the other one, targeted therapy. Currently, we have the HER2. So targeted therapy are a treatment that targets certain kind of protein in the body that is hopefully expressed more in the cancer cell. So for example, for HER2 targeted therapy, that's why we check with their cancer cells, do they express that receptor? If they don't express the receptor, so the targeted therapy won't work. Okay. But our body also has the protein, like for example, the heart also have some of this protein. So that's why when we give the targeted therapy, we have to monitor their heart. And it's usually reversible. If we find the heart function kind of go down, if we stop it, it usually improve. Okay. So the other one is radiotherapy. Radiotherapy, we use X-ray to target the DNA of the cell. So when it tries to grow, it will kind of die off. Okay. Especially the cancer cells, like I said, is active. So usually radiotherapy, we have to have a target. So for breast cancer women, especially if they just have the lump taken out, not the whole breast. So we have to give radiotherapy to the whole breast to reduce the risk of the cancer forming in other parts of the breast. So that's radiotherapy. But some patients, even if they have the whole breast taken out, if they still have high risk of the cancer coming back to the chest wall or to the nodal area, then we give radiotherapy to that area after the surgery. So radiotherapy is done after the surgery. Chemotherapy and targeted therapy can be done before surgery to shrink the tumor, because we know if we can shrink the tumor until it disappears, what we call a pathological complete response, the outcome is better. And if they don't disappear, we would recommend more treatment to make sure that it doesn't come back.
Yeah. While you're explaining all of this, I'm just thinking about what a patient really actually goes through. It's not easy. I really respect them. It's not it's a big hurdle that they have to overcome, and it really takes a toll on their physical state, even mentally and emotionally. So it's not easy.
Yeah, it is too much information, isn't it? So I try not to bombard them with all. And we treat sort of individual patients based on all those risk factors, their own factors. And then we explain one by one.
Because the support, the care that they need, it differs, right? It's
too much information, so we will give overview and we focus one by one. So if they need chemotherapy and targeted therapy first, we explain more on that. And then they will have surgery. So after surgery, we need to look again at the tissue under the microscope, and then we explain the next step. So it's easier for them to take in.
I think that's why in this profession, both of you as doctors, the emotional element or the emotional intelligence is really critical. How you talk to a patient, how you deliver news to a patient, how you explain what they're going through, that really makes a whole difference about how they feel about their future. So the diagnosis, usually they would come to you, Prof. Adlinda. You are a consultant clinical oncologist, right? So would it be correct to say that the treatment part, if let's say they need surgery, that's when they'll see someone like Prof. C, a breast surgeon. Is that right? So what happens after all of that? Then they have to go and see Prof. C for surgery. What is the process?
Normally they see the surgeon first.
Okay.
Because they diagnose usually via the surgeon. They arrange all the biopsy and all that.
Okay. So they see someone like Prof. C first.
They will come and see us first.
They get the diagnosis, and when they do, they see someone like Prof. Adlinda to find out or identify which is the right treatment that they will need. Is that right?
So before this, the important is normally patient will come to see surgery or surgeon first, long before the condition, the services. But nowadays we know sometimes patient also need chemotherapy before surgery. So we are stuck. Initially, when they come to see us, we perform the triple assessment. The surgery, the examination of the breast by the doctor. Then we'll do an imaging like mammogram and adjunct with ultrasound. Then after that, we will put in a needle. So we'll take a biopsy from the tumor or from the area that's suspicious. If very small, then our radiologist will do it. So all these things is not alone by us sometimes. So we really need a team to come in. Because nowadays, the treatment is more and more advanced. Not only surgery first, then only continue with other treatment. So sometimes we need to cross treatment, like we have a chemotherapy first, we call neoadjuvant chemo, especially for our high risk type of cancer like triple negative or HER2 enriched type. So we will really, after the diagnosis, we'll come together with our oncologist, our radiologist to discuss. Then if we think this patient is suitable to go for neoadjuvant chemotherapy or targeted, then we will refer patient to oncologist straight. Before surgery even. Yeah.
This is what we call multidisciplinary fields, doctors of different expertise come together, they work as a team for that same patient. Prof C, can you talk about something called mastectomy? I think maybe a lot of us have heard about it, but don't know exactly what it is. What is it? When is it typically recommended? And what factors influence whether a patient undergoes a full, partial, or radical mastectomy?
Okay. So in this breast surgery field for breast cancer, we have started with removing the whole breast, long
You see
time
sometimes
ago.
celebrities, Hollywood celebrities doing that even before a diagnosis because they know they have a history of breast cancer. So they make that conscious decision to remove both of their breasts.
So that one we call risk reducing. Reduce the risk.
Okay.
So generally when we talk about breast cancer treatments in surgical side, so we have two types. We have one, preserve the breast. We call breast conserving surgery. So you only remove the tumor with the normal tissue around adequately to make sure the surgery is clear, right? And the axilla, or we call the armpit here area here, we have a lot of axillary lymph nodes. So we also have to remove some. If they are early cancer, we call sentinel lymph nodes biopsy, right? So all this is a package. So when we talk about when the tumor is big and then involve a lot of area, then the patient is not suitable for lumpectomy, or we call breast conserving surgery. Then we have to sort mastectomy. Mastectomy means removing the whole breast.
Yeah.
But long time ago, our mastectomy is called radical, means we have to remove the breast, the skin, everything, the muscle as well underneath. So that time was started by our Professor Hosted. But the surgery caused a lot of issue to our patient because patient do have a lot of pain, chronic pain after surgery, and then the wound is difficult to heal, all that. So with the new type of research, then it moved up to better type of like preserving muscle and keep the skin sometimes, because early breast cancer, they don't involve skin. They are safe to be preserved. So we've moved on to more and more minimally invasive surgery now. And mastectomy actually removing of the, you can see here, just remove underlying breast tissue. So we don't remove the skin anymore nowadays for early breast cancer. And at the same time, you can add on, we call rebuild the breast, breast reconstruction for patient if they have to sort a mastectomy as one of the treatment because a lot of area involved or something like that. So all these have changed different opinion as well as different new type of treatment era that patient don't really have to lose their breast, even they have to sort mastectomy because they can rebuild back their breast.
Yeah, I think technology and innovation have definitely changed the way surgery can be done for a patient who needs surgery. But what about those who really need to resort to mastectomy and they lose both their breasts, let's say the whole organ? As we know, as women, we cherish that as part of our anatomy, our body, right? How we define ourselves with that. So when you see patients that have to remove their breasts, how does this influence them or affect their emotional well-being, their mental well-being? What do you see?
So when we talk about when they really have no choice, have to remove the breast, if those who doesn't have any medical illnesses, actually they can opted for breast reconstruction immediately or delay type. So even though they lost a lot of skin, but we still can find out other place, Sometimes we do combine with our plastic surgeon together to rebuild the new breast for them. So when we talk about older age patient, so their medical illnesses sometimes not allowed them and unable to allow them to move on to a longer surgery.
Okay.
So actually they have other options like using outer type of prosthesis, breast prosthesis, and it can really balance their shoulder after surgery as well. Yeah. So all these things have moved on to more and more new things for our patient, and it really is a good news because they don't even when they wear their clothes after
Yes.
the surgery,
Yes.
without any rebuild of the new breast, they can put a external prosthesis in front, just in front of the inside the bra. Then when they wear normal, it really looks like normal, you know.
Okay, because we know that something like this, a surgery like that, will affect someone's self-esteem, self-confidence, because it's about body image. That's something that is very precious to us, especially to us women. But how is the recovery process also like after surgery?
So recovery very crucial in terms of whether they can combine the issue of like nutrition plus our physiotherapy and the exercise part, you know. So for wound healing, they really have to eat well. They need a lot of nutrients, they need a lot of proteins for that. At the same time, because after we remove some lymph nodes in the axilla here, armpit, so we need physiotherapists to help them to reduce all the swelling on the hand sometimes, you know, to relieve all the water retention. And then exercise is another one that rebuild their confidence as well. So all this, we need some combination of all these things because after surgery, the range of movement of the hand sometimes will be slightly affected if they don't move their hand after surgery, very scared to move, but actually they can move like normal. So we have a team together to help them and guide them what to do after surgery as a recovery.
Okay.
So once they recovered from that, the period like 1-2 weeks, then we will move on to bringing them to meet our oncologist like Prof. Adlinda for further treatment. Yeah.
How long will this go on?
So it generally range from 1-2 weeks to a month. Yeah.
Okay. And then when they go to Prof. Adlinda, then you'll make that decision whether they'll need chemotherapy, radiotherapy, targeted therapy. Can you elaborate further? I know you've touched on that already, but how is that? Can you illustrate to us the journey that a patient will go through in either one of those therapies?
Okay, so as I mentioned earlier, every patient is different and their cancer is different.
Yes.
So what stage, what grade, etc. We will evaluate all these to see what are the risks of the cancer coming back, and then what subtype of breast cancer. So we will make a plan based on this.
Okay.
It's not just sort of the risk of the cancer coming back, also the risk of the patient undergoing the treatment. So we have to balance the risk and benefit. So I think patient sort of education is very important. So if they know what to expect in terms of side effects and what will happen next, is better for them. And for example, earlier, like before surgery or just after surgery, usually the surgeon will, refer to physio and all that. We need to emphasize the importance of doing the exercise, because subsequent treatment, for example, like radiotherapy, we need the patient being able to raise their arm. So because the radiotherapy use X-ray, so we shine X-ray from the side. We want the arm to get out of the way. So they have to be able to raise their arm.
Okay.
So we need to tell them it's important for them to do the exercise so that they can move their arm, quite well. And this exercise should continue or indefinitely, because the tissue can sort of get together and it becomes tight. So it's important for them to continue the exercise. Sorry, back to the treatment. So based on what we find from the surgery or from the earlier investigation, we will talk to patient what additional treatment that they need to reduce the risk of the cancer coming back. Basically, it's like, if you have weed in the garden, you think you remove everything, but it still comes back. So you need to do extra, right? You need to put maybe some chemical or some things to make sure that they don't come back. Kind of similar.
Yeah.
Even though the surgeon remove everything that they can see, and we do the scan is clear, but we cannot see if there are cancer cells because they are too small. These cancer cells can start to grow again. So basically, all the other treatment that we give is to make sure that we eliminate all the cancer cells so they don't grow again and come back as cancer, either in this area, the breast area, or elsewhere. So yeah, as I said just now, we consider each patient whether they need chemotherapy,
Yes.
whether they need hormonal therapy. Only patient who has hormone receptor positive would benefit from hormone therapy. If the hormone receptor is negative, they would not benefit. So the patient cannot compare, why do I not get chemo or why do I not get hormonal therapy? So it's different based on the type of or the subtype of the breast cancer that they get. We also consider targeted therapy and just now radiotherapy, So every patient is different.
Okay.
We see what treatment is suitable for them, what would benefit them. And if they don't benefit from chemo, then we won't give chemo. Usually like the hormone positive, the small, tumor, we think the risk is higher than the benefit, then we wouldn't recommend that.
Okay.
Yeah.
While the treatment differs from one patient to another, what I think is guaranteed is that there is a change of lifestyle that they will need to follow through indefinitely. You mentioned, Prof. C, about nutrition. I think so, meaning the food that they take has to be different. The menu, the dietary habits will have to change. Is that right?
So not so about habits, but the food that they choose. Yeah. So because what we say, because they have to go through a lot of treatment, that is the one that we really don't want them to cause a lot of wasting to their body muscle, and the health is very, very important. They need to have enough body health fitness to go through all this treatment. So that's because we know lifestyle is food, nutrition, exercise, as well as other things, right? So all these have make all of our teams understand. Apart from that, psychological part also very important. They need to have very strong mental preparation. Like Prof. Adlinda just now talk about. Even before surgery, before chemotherapy, the surgeon already prepare them, So I always prepare my patient and let them know like this type of disease that now, let's say they are triple negative disease. So they need to go through chemo first, So chemo, then only surgery, then only like further other treatment, you see. So all these things they need to have mentally prepared, because if not, then they'll say, I thought only surgery enough for my disease, which is like nowadays, only stage 0 disease, you don't need extra a lot of things. But stage 1 nowadays, also we are looking at more and more advanced treatment so that they don't come back, the cancer don't come back and relapse, what Prof. Adlinda said.
Yeah. Since you brought it up, stage 0, how does that defined?
So stage 0 is what we call just now ductal carcinoma in situ.
Okay.
Means the membrane, cell membrane, they haven't breached that area, like the overgrowth of the cancer cell. They are only growing inside the gate, So they haven't go out. So we call them stage 0.
Yeah.
So they have 3 types as well. So the low grade one, they are sort of like still very, very low, less aggressive. So we normally treat with surgery is more than enough. But the intermediate and high grade, sometimes we need to add on a little bit of radiotherapy, So, but the treatment is not so complex like our stage 4, stage 3 disease. Yeah.
That's why early detection is very, very crucial for all patients, no matter what age they are at.
Yeah.
Now, for those who are watching, maybe they themselves are going through breast cancer, or they may suspect something that they might have some something cancerous in their body, or they're taking care of someone who has breast cancer. Prof C and Prof Adlinda, what would you have to say to them? Maybe we can give them a little bit more courage, encouragement, semangat sikit, to go through what they're going through.
I think whatever we are seeing here, right? Important is early detection, because early cancer, like stage 0, just now we talk about, less treatment, less trauma, less emotional distress, a lot of things, and financially, whatever treatment cost is very less. If they can achieve early detection, that is superb and great. But when we talk about stage 4, like Prof. Adlinda said, we really have to look for other things, a lot of choices, a lot of types of treatment they need, and the cost is more and more. So early detection really save life. Please come early for screening. Screening at 40 years old with mammogram every 2 years up to 74 years old. Or if you are high risk, like family members have breast cancer, so you need to come early and meet your doctors so that the doctor will give you a guide, how to screen.
Prof Adlinda?
Same. The earlier is detected, the higher chance of cure and the less treatment they would need. If they present late at stage 4, they need one treatment after another to control the cancer. And it can cause more symptoms. So the earlier it's detected, the better. We can try to aim for cure, and they might need less treatment rather than more treatment to achieve that.
But no matter what stage that they are at, I think what's important is that we let them know they are not alone in this journey. While they have their family members to also care for them, they need that support system. I think it's also important to note that at UMSC, you'll get a team of great doctors like Prof. Adlinda and Prof. C, who are very nurturing, very caring, very empathetic as well towards what your patient is encountering or experiencing. So thank you for part 1, Prof. Adlinda and Prof. C, for unfolding or unpacking what breast cancer is. So again, to all of you, if you're already reaching the age of 40, go and get a mammogram, go get a screening. Early detection is key. That is what we aim for.
Did you enjoy today's curated episode? Well, don't forget to tune in for the next episode of Curated Podcast by UMSC. To learn more about our consultants, specialties, or to book an appointment, visit umsc.my. For health tips, behind-the-scenes content, and expert insights, follow UMSC on Instagram, Facebook, TikTok, Spotify, and Apple Podcasts. Till next time!